Hi everybody, this is a video about chelation therapy. Just before I jump into the crux of the video, if you don't mind taking a quick second to please like or share or subscribe or post a quick comment on the video, I'd really appreciate it. So thanks in advance for taking a second to do that. And as per usual, nothing I'm saying should be construed as medical advice. This is for informational purposes only. If you need medical advice, please talk to your healthcare provider to get that advice. So someone posted a question on one of my other videos, and it says, question about heavy metal chelation, EDTA, EDTA being a heavy metal chelating agent, kind of best known for, or it's best able to chelate lead and cadmium and aluminum from the body. So a question about heavy metal chelation EDTA causing hypocalcemia, then death. Can you explain, is that true? So thank you for the question. Good question. If you were to go on a search engine and plug in EDTA chelation therapy toxic or causes death or something like that, unfortunately you would find reference to a couple of case reports where some folks did die from chelation therapy. But before you run out of the clinician's office that's administering your chelation therapy right now, or before you cancel your next appointment for your chelation treatment, please listen, because there are some important details where, in my opinion, as I've said in some other videos about chelation therapy, I think it's a very, very safe therapy, and I think the risk of death from chelation therapy is astronomically low as long as it's being used in the proper, responsible way. So I'm going to explain why in those case studies, to my understanding, it was not being used in the proper, responsible way, and that unfortunately led to a couple of fatalities, which is really, really awful. But it's not something that is broadly applicable to chelation therapy, thankfully. So with chelation, with EDTA chelation therapy, or the EDTA, the chelating agent, there are two different types that clinicians like myself can access. There's disodium EDTA and there's calcium EDTA. If you were to look at the molecular structure of EDTA, it has this kind of weird shape to it. It's got basically, I'm trying to do this with my fingers here, it's kind of got four binding regions. So my thumbs and my index fingers there would be the binding regions. And with disodium EDTA, it doesn't have any calcium bound to any of those four little binding regions or those binding domains, whereas with calcium EDTA, two of those four binding domains are bound up to calcium. I can't remember off the top of my head whether it's the index fingers, the thumbs, or maybe a mishmash of those, but two of those four binding locations binding domains are bound up to calcium. So when we use the disodium form, the one that doesn't have any calcium bound to it already, then we have to administer that really, really slowly. We'd administer a full strength dose, usually over not less than 2 hours. Preferably it would be over 3 hours. And the reason behind that is that the chelator, this EDTA, has a strong affinity for lead, has a strong affinity for cadmium, aluminum. It's actually got quite a strong affinity for mercury, although usually we use a different agent called DMPS to chelate mercury. So it's strong preferences to bind those metals. But if it doesn't have easy access to those metals, if those metals are really tucked deep into the tissues, or if there's maybe not that much heavy metal in the first place because the patient's already done a number of treatments, or maybe they didn't have that much metal in their system, like heavy metals in their system in the first place, then those binding sites will settle for other things. And those binding sites on the little on the EDTA molecule, they will bind minerals, including calcium. And so we have calcium floating around in our bloodstreams. We keep a very tight control over the amount of calcium floating around in our bloodstreams, because if the level gets too high or too low, it can cause major health issues and fatality. And so unfortunately, if a clinician were to administer disodium EDTA really quickly over markedly less than 2 hours, then it can cause a plummeting of the calcium, because basically the EDTA rushes into the bloodstream, and it only has, it takes some time for it to diffuse into the tissues to actually bind the heavy metals that are hiding out in the cells. So if we put a ton of it into the bloodstream all at once, there's going to be a high concentration of it in the blood. It's going to kind of bind the first thing that it finds, and it's going to run into things like calcium a heck of a lot faster than it's going to run into lead and cadmium and things like that. And so if it's administered very quickly, then it can cause a rapid drop in calcium and cause, so known as hypocalcemia, and cause major symptoms and potentially death. And so that's the disodium type. The calcium EDTA, again, already has some calcium bound to those little binding sites. And so the calcium EDTA, not every clinician uses it this way, but many clinicians use it as where it can be administered quite a lot faster. So there are some clinicians who actually will administer it as a 2-minute push, as they call it. But you're just hooked up, a little syringe is hooked up to the vein using usually a butterfly needle with a little tubing attached, and it's just basically slowly pushed in over about a 2-minute period or a 5-minute period, 10-minute period, but can be done in as little as 2 minutes, or other clinicians will drip it over a longer period of time. But the calcium EDTA, based on my experience at least, even when administered as a 2-minute push, which is way shorter than 2 hours, it does not induce hypocalcemia and death. There have been no reports of that to my understanding. So my understanding of it is that those couple of instances where EDTA caused hypocalcemia and death, unfortunately, were due to medical errors where I've heard different versions of the story, and I wasn't there, and it's not something I've seen in the published literature. It's just in the case reports, it's like this happened due to a mistake. But my understanding of it is that whoever was running the IV grabbed the wrong EDTA. They grabbed the disodium stuff instead of the calcium stuff. They administered it as a quick push, and then unfortunately the person, and again, I believe, to my understanding, happened a couple of times in sort of recorded history, like in published history. Unfortunately, those people died because it's really the thing you're not supposed to do. I guess sort of a rough analogy would be, we can all agree for the most part that water is good for us, but you wouldn't want to give somebody 1,000 liters of water all at once, because they would drown in that water. So it's just basically too much of a good thing, too quickly, essentially. So in terms of inducing hypocalcemia, my understanding is that's the way that EDTA can do that, and it would be very dangerous to do that, as we've just discussed in these couple of unfortunate tragic incidents. But if the EDTA is being used in a responsible way, in a it was an accident, which still shouldn't have happened in those cases, but it wasn't done intentionally. But as long as EDTA is being used in a very responsible way, the appropriate way, then it does not induce hypocalcemia or death. So it's generally very safe, well tolerated. There are large published research trials showing that it's very safe to work with, and that's certainly something we've seen clinically. In my clinic, we've administered thousands of EDTA treatments over the course of time. We've done disodium types, calcium disodium types, calcium EDTA and disodium EDTA types, and very safe. Never seen hypocalcemia, never seen any fatalities, thankfully, and nor would we expect to ever see those, because we use it very responsibly. We have our calcium EDTA in one location, our disodium EDTA in another location. We've got the disodium ones in a box that has to be opened up. So we have these extra checks and balances, because when we do chelation therapy training, at the courses I've been to at least, we basically get the pants scared off of us of ever making that mistake. And so, hopefully nobody will ever make one of those tragic mistakes again. So I hope that this answered your question. If anybody has any follow-up questions on this or comments, anything you want to share in the comment section about your experience with chelation therapy, whether it's helped you, whether it's not helped you, whether a certain approach seemed to work well for you, or anything else you want to share around it, happy to hear about that. And if you have any questions about any other topics, please feel free to post in the comment section below, and I will do my best to answer as soon as I can.